All right, everybody, Mother's Day is around the corner, and while we celebrate moms and babies every day in our job, we want to do something special to celebrate you at home. So we're going to be doing a giveaway for an Amazon gift card.
We're thrilled that you're here, that you found us, and that you take the time out of your day to listen to our podcasts. It really says a lot about the mom that you are, the mom that you want to be. And we're going to celebrate you with, as she said, the Amazon gift card, $20. So what we'd like for you to do is to go onto one of our platforms, smash that little button that says follow or subscribe. And then if you'll go into the comments and just comment Mother's Day.
Mother's Day.
We will look at all those comments. We will put the names into a randomizer app on the computer and let it just select one. Then we'll come back and reach out to the winner. And so just go ahead and give us a like and a follow. Share it with your other mom friends. We would really appreciate that. We'll do our drawing on May 9th and we'll reach out to you then.
Yes.
Good luck. And
you're doing a great job. Go heat up your coffee.
Yes. Keep being awesome.
The information in this podcast is for entertainment purposes only. Consult your healthcare provider for proper care regarding your specific situation.
Welcome to Rattle Nurses, the podcast that's here to shake things up when it comes to pregnancy, breastfeeding, and postpartum care. Hosted by two experienced nurses, we're bringing you real talk, expert advice, and a whole lot of laughs as we navigate the wild world of newborn care.
Whether you're a first-time parent or adding another little one to the mix, we've got the tips, stories, and answers you need to make this journey a little easier and a lot more fun. So grab your coffee, even if it's cold, get comfy, and let's dive in.
Okay, welcome back, guys. This is episode 5, probably entitled, Is My Baby Okay? We're going to be talking about some things, some newborn testing, some normal stuff. But I'm going to start out with a joke. Delena, do you want to hear a corny joke?
I'm all ears.
All right, this is a kid-friendly joke. Most of them, I try to make them mostly kid-friendly, but what was it? What do you call a bear without, what would a bear be without the bees? Ears. Just ears. No bees, just ears.
True. Yep.
It was a little silly. Did I tell you the one? My nephew did tell me one the other day. I don't know if I did this one yet, but it was, this is super common, but he goes, what is a fish without eyes? Shh. No eyes. It's so stupid, but it makes me giggle every time.
Right? I hadn't heard that one before, though. But yeah.
Oh, I just thought of another one I saw. Okay. It's like, oh man, time flies like an arrow, but fruit flies like a banana. Banana. Fruit fly.
Yes. I got it.
Okay.
Not sure Mr. Ed did.
Didn't. That's what I was going for. All right. This is back to our mini series that I'm calling Names That Would Be Kind of Cool If They Weren't Actually Things. So again, I have
oh my Lord,
my list of names on my little flashcards, and I'm going to blind react for Delena and see what she thinks of these names. Maybe you'll like them. Maybe you won't. Maybe. Again, I'm not insulting. If you've named your child one of these things, it's funny to me. Oh my gosh.
Misogyny. Oh my gosh.
Call her Missy. Misogyny. Come here, misogyny. It is time for dinner. Stop playing around in the mud, misogyny. Misogyny, Lou. They're not funny.
Oh, that's funny.
This one's a pretty good one.
Saline. Oh, I can.
You could be from the South. Celine?
I can hear Dolly Parton singing it right now.
Saline, saline, saline. Right there.
Oh, Lord.
That's a good one.
I'm sorry, y'all.
It does sound pretty feminine, though. Saline. Okay, next one. I don't know why this is so funny to me, too. They're all hilarious.
Debris. Oh, Lord.
Hi, my name is Debris. You can call me Deb. You can call me Ree. I'm Debris.
Oh, Ree. Yes.
Ree. Debris. It's Ree for short. Okay, one more. Last one. This is so much fun. I don't even know what I'm going to pull up again.
I never even thought of debris. Oh, my God. So funny.
Oh, my God.
Corrugated.
Corrugated. Like boxes. Call her Cora.
Oh, and I love the name Cora.
I like the name Cora, too, but when this came up, I was like... Corrugated.
Yes, absolutely.
It's a family name. From the Box family line. Corrugated.
Yes. The Box family. Cora Box.
Corrugated and cardboard. We all start with C's. It's a tradition. All right, guys, that's enough of that. I'm sorry. I had to take my mini segment there.
We apologize.
Okay, so yes, we are going to talk about normal testing in newborns. We'll talk about blood sugar testing first, and then we're going to talk about the newborn screenings, which sometimes vary state to state. So that we'll get into that. But starting off with blood sugar testing. If we are having to check for blood sugars on your baby, there are a few reasons why. And it is mostly to keep your baby safe. We want to make sure your baby's okay and transitioning well. So there are hospital protocols in place for specific maternal conditions. Say you were diagnosed with hypertension, which is high blood pressure, gestational hypertension, high blood pressure during pregnancy, diabetes, if you're diabetic and you're insulin managed, or if you're just gestational diabetic. Either way, those types of things we do want to check baby's blood sugar for, and our facility does sequential blood sugar checks. I think we've touched on this a little bit before. It's got to be a certain number, but what we do in that situation, and we don't do it on baby's fingers, they're too little. When we do most of our checks, we'll warm up their little foot, put a little warmer on, and then do a little poke on their heel, and we'll get our lab work from that and our blood sugars from that. But so we'll follow our hospital protocols according to that. We will make sure your baby's feeding or transitioning well, if you will. There are some factors that affect low blood sugars, which is something that we try to prevent. We don't want your baby to have constant low blood sugars because we try to keep them out of the NICU.
Yes, absolutely.
So things that can affect that, if your baby is not getting enough to eat, or if your baby's cold, having cold stress, that can burn a lot of their little calories. If your baby's having
difficulty latching.
Yes. Okay.
They can exert a lot of energy just trying to latch to breastfeed. So we'll spend a certain amount of time, but after we get past, like 15 minutes of trying to get baby to latch, we just need this baby to eat.
Yes. We've burned a lot of calories just trying.
Dropping a blood sugar.
And especially if your baby's kind of borderline on their blood sugars anyway, we want them generally at around 50. So if your baby's last blood sugar was 50 and it's been 3 to 4 hours and you haven't called your nurse to say, hey, we need a latch again, and you're like, it's been like 5 or 6 hours since they've eaten, I'm going to tell you it's going to be low. It's going to be low, and we're going to have to treat that. We're going to have to intervene and do something about it. So that's why we want things that can try to keep that blood sugar stable, feeding consistently or on demand, whether that's breast or bottle, don't care. Feeding consistently, which is every 2 to 3 hours, and letting us know before you're feeding, and then trying to obtain a good feed or a good latch.
And if their blood sugar is already low, it's very hard to get them to latch sometimes because they're so lethargic and sleepy from that low blood sugar that can pose an issue sometimes.
Or if they've gone 5 to 6 hours without eating.
Yes.
What happens to you when you go 5 to 6 hours without eating? You're tired. You don't want to deal with nothing. You get hangry. So, I mean, think of it for your baby too. We're not just going to let them sleep. We do need them to pass the protocol or to pass the sugars so we can adhere to the protocol so your baby can stay in the room with you and room in with you. So I feel like I need to drive that home. We're not doing it to be mean.
Yes.
I don't like poking your baby, but I'm going to do it to keep them in the room with you to keep them safe.
Yes. And so many mamas say, but she's sleeping.
I know. I'm so sorry.
We know, but
It's
polyester needs to eat.
polyester. By the way, if y'all haven't met our baby, this is Polly. Middle name Esther is polyester. So yes.
I really tell moms, like, the first 2 weeks of life, usually you have to wake them up to eat. Not always, but a lot of times there's going to be a point where you do have to wake them up to eat. After that, your milk is in, things are going great, then you can usually just let them sleep. Their blood sugars are regulated, but prior to that, we need to make sure that they're eating every 2 to 3 hours.
Yes. Okay, so what happens if they have a low blood sugar and we have to do something about it? Well, if your blood sugar's low, what's happening? Your body's burning off calories and really your brain's not getting enough blood sugar. So really, we need to get some sugar in you. So what we do in our facility, we'll give a little bit of gel, and it's a dextrose sugar-based gel. To me, it smells like straight cotton candy. But we'll give a little bit of that, and then we'll try to get them to feed, whether that's on the breast or the supplement. We need them to have that milk, that protein to carry them through.
And how much we give them is weight-based.
Yes.
And it's based on the doctor's orders. So we always give the appropriate amount, not too much, not too little. And it just goes, we actually take a gloved finger and we dry the inside of the baby's cheek. And then we take that gel on our finger and we put that inside baby's cheek and massage it in because it absorbs quickly into that
Mucous membrane.
To get that blood sugar up.
Yes.
And then we want you to feed afterwards.
So yes, we need that protein from your milk or from the supplement to carry that baby's blood sugar through to the next check. We'll then continue to check until it stabilizes. So
Yes, typically we have to get 3 blood sugars that are consecutively good before we can stop.
So if that's something too, if your baby's blood sugars are just not staying up and you're trying to exclusively breastfeed, maybe discuss with your partner about maybe we can supplement a little bit just to keep our baby on the floor with us. Because what we don't want, as I've always said, is we don't want your baby to go to the NICU with an IV. Sometimes it's inevitable. Sometimes if baby's got metabolic issues, it happens. But we try our darndest to keep your baby there with you. So if that's something that comes up, just know that it's a normal process.
And I can tell you that after we give, if we have to give the gel 2 times, after that second gel, not only do you breastfeed, but we also need to supplement at that point, whether that be with donor breast milk that comes from the donor milk bank or formula, whichever you prefer. But we do need to do both.
Or if you can pump, if you're able to somehow pump out that amount postpartum, by all means, I would love to give that.
We
Phenomenal.
just have to know that the volume is there.
I just need to know that the volume is there. So, yes.
And we do want to, we always offer a breast pump at that point as well. If you're having to supplement your baby and your intent is to breastfeed your baby, then if supplement is required, then we always want to start you pumping.
Yes. We want you to get that stimulation so your body can start making milk for your baby.
And when we have you pump, we want you pumping ideally every 3 hours to mimic, what the baby would be stimulating you as well, so that your body will make the amount. It's a supply and demand thing. So
yes,
that's what we ask you to do.
Also, for it to be known, because babies can burn a lot of calories and burn off their blood sugar in this time, we do withhold baths. We don't bathe them during this time. If we're trying to get their blood sugars to stabilize, we're gonna hold off on the interventions like baths that will burn their calories, basically waste their blood sugar. We don't.
Oh my goodness, they get worked up.
They do. So that also includes, like, if you've got 1,000 family members there, passing baby around, unwrapping baby, putting clothes on baby, those things as well will burn calories unnecessarily. So keep that in mind. Usually we just prefer skin to skin. That's helps regulate blood sugar, your breathing, or baby's breathing, baby's heart rate, regulates everything as a smoother transition. So if your baby's trying to recover from blood sugars, we're testing blood sugars on baby, please don't try to change their clothes 47 times. Don't pass them around to every family member. It's burning calories for them.
Mm-hmm. And also, we were talking about the reasons why we do blood sugars. If you say, oh, I wasn't diabetic and my blood sugar was great, we also have to do it if baby is small or large for their gestational age.
Good call, yes.
Based on, if you had her or him, more than 3 weeks prior to the due date, we have to get blood sugars on all of those babies, just because their systems are immature. Also, if they're less than 10% of the ideal birth weight or greater than 90%, we do get blood sugars on those babies as well.
Usually hospitals have certain parameters on the specific diagnoses or reasons, rationales why we do blood sugars. Or like for another one of ours is if your baby comes out stunned and they have a low APGAR and after delivery they need to intervene and give your baby, they're stressed out. If they're giving your baby oxygen or helping baby breathe, something like that, those types of interventions, then yes, we're going to monitor blood sugars to make sure that baby didn't endure too much stress and is able to transition a little bit better.
Yes, and no prenatal care because we don't know your
history. Don't know your history. We don't know your diagnoses. You may feel like you've had a healthy pregnancy, but yeah.
So I feel like there's more and more conditions added all the time.
I think we've talked about there's just been more and more sick mamas lately. Really is. So yes, I feel like most of our babies, more often than not, we have to check a blood sugar on a baby. So that's why I'm trying to drive this home. If your nurse is talking about supplementation, be open to it. So yes, please. We're just trying to keep your baby with you. Okay. Next, we'll talk about newborn testing and 24-hour care. So at the 24-hour mark, usually, give or take, our hospital, our entity does what we just call our 24-hour cares is what we call it. But it consists of the newborn screening, which is our Texas state mandated test. We'll get to that in a second. A heart disease screening, which is also mandatory. The jaundice test and can't think of words right now. If we have to check a serum bilirubin, we'll do that at the time too. We'll do a couple of other little things like overall weights and assessment, but those are your pivotal ones.
Yes. Oh, and at that 24-hour mark, I have so many parents get alarmed because the clamp on the cord disappears.
Yes, we've talked about that too. Yes.
We take that off then,
yes,
typically.
If it's dry enough and it's not like one of those fat squishy ones that needs a little bit of extra time, we'll take off that cord clamp at the 24-hour cares so that it's not being tugged on anymore. I usually try to show that to them, be like, hey, I took this off too, so they're not alarmed. But yes.
Don't be worried. That can't just fall off. We take it off.
Yes. We usually we do a hearing screen prior to leaving the hospital. That may or may not be done with 24-hour cares, just depending. Our hearing screeners are around during the day. So sometimes we'll try to consolidate that all together so that that testing is combined. So it may or may not be done with the 24 hours. It may be done a little bit after, but that's usually a separate screen done by an outside facility. The heart disease screen, we do check. It's just a simple pulse ox. It's no pokes required there. It's the thing that measures your oxygen that we'll put on like what would fit on adult fingers. We put it on baby's hand and foot, and basically that's comparing is the blood to and from the heart, essentially making sure there's not any significant defects. Sometimes there's underlying things and babies still can pass the heart disease screen. Again, that's why it's important to follow up with a pediatrician.
Sometimes we're surprised when the baby doesn't pass because their color's been great, their respirations have been wonderful, and sometimes they'll just surprise us and they can't get, their oxygen levels up to, we really want to see them 95% or higher and within 3 points of each other.
Yep.
If they're not, it kind of signals us that there may be something going on.
Yes.
And then, we'll usually get some blood pressures, which is not a typical vital sign that
For
we get in
babies.
newborn babies. NICU does. Well, babies, we do not typically, unless we hear a murmur or something along those lines.
Yes. So that's a big indicator. Essentially, there's a big fat hole in the heart, and that happens when babies are born, and that's necessary for them. And we need to know that things are progressing, and that's one of the ways we can measure it without getting too invasive. So again, we put a little sensor on the right hand and one of the feet. Usually I do the left foot, but measure our little percentage there. Next thing, we're going to talk about the PKU test.
Yes. So sometimes you'll hear it referred to as newborn screen, or some people call it PKU. I feel like PKU, calling it PKU is traditional name that people refer to it, and that's what they know.
A lot of people do blood spot test.
Yes.
Blood spot test.
And the PKU is actually one of the things that we're testing for when we do the newborn screening. However, and every state is different. From what I've read, almost all states require some form of newborn screening, but they're all completely different. Here in the state of Texas, our newborn screening consists of screening for 56 different tests, and many of them are things that you've probably never heard of. Really long, complicated names, but we test for their blood, metabolic, genetic disorders, and things that you could never look at a baby and know that they have them.
This seems superfluous to some people, but it really has some very devastating genetic disorders that they do test for, that if your baby, heaven forbid, if your baby is diagnosed, then you need to know as quickly as possible so that you can help them live their best life. I mean, help them facilitate it.
And like I said, I don't even know that I could read all of these.
I do tell
these
my
names
moms
are
that.
crazy.
I was like, it tests for, here's things that you might have heard of, and here are things that I can't even pronounce.
But I would say some of the most common ones that most people have heard of are cystic fibrosis, congenital hypothyroidism,
Sickle cell.
yes, sickle cell.
The PKU, which is phenylketonuria, that's also one. That's why they kind of shortened it. And there's some pretty serious ones on there.
Yeah, there's sickle cell, and again, some of the muscular dystrophies.
Yes, like SMA.
Yes. SMA is the one that really stands out
Yes,
to me.
that one's a major one. That's why it's important to choose a pediatrician, because what will happen is, even though you're not staying, sometimes it takes several days to a week to get the results back. And usually I tell most parents, for this type of test, no news is good news. The state doesn't seek out to call everyone and say, okay, your test is fine. But what will happen is, if there is a prompt, or if the baby needs an extra screen, or if there's something abnormal, they call the hospital or the number that's on that form, and they give us your information, and we pull it up and we say, oh, they're going to follow up with this particular pediatrician, and they'll ask for that pediatrician's name. So the state calls us, and we call your pediatrician to let them know. They also try to call the pediatrician too, to let them know. So that's why it's so important to let us know what pediatrician you're going to use. We're not being nosy. It's for the follow-up in this situation.
Which has actually happened a few times.
Yes.
In the recent future.
I have a story about...
Or recent past.
There you go. I didn't even pick that up. Recent future. Like, I can tell in the foresight.
Yes.
Another one of the disorders that is checked for in the PKU is SMA, the spinal muscular atrophy. Did I say it right?
Yes.
Okay.
You did.
Okay.
You got it.
I always just say the letters and I forget what it stands for. But it's can be severe, and it's one of its forms. It has several forms, and I believe they're ranging from stage 0 to 4, with the 0 being basically infantile, immediate onset, and then stage 4 having the most survivability. With that being said, I do have a story. I had a family, or the state did call us one time on the unit and ask for this pediatrician because they had diagnosed this baby with one of the, I forget which one specifically, but one of the more rare forms of SMA. Mm-hmm. So they asked for our information, or the parents' information, their emergency contact, all that information. I was super hesitant because I didn't want to start giving out all this information to this person who I'd never met. But since they had told me that this particular diagnosis may require, the infant may expire within the first couple weeks, if there's no intervention or treatment, or without having been seen by a physician, the family would know. I mean, they need to know these things. So we had to give out the emergency contact and the address so that if they didn't answer their phone immediately, then they would send out a sheriff to their home to inform them of this, because it's such a dire diagnosis. I don't know the progress or anything of that, but that's why these screens exist. So we know what we're dealing with, so that you can be better prepared. You can be knowledgeable. Is this something that's how badly is this going to change things for you? Or what are we going to have to do to prepare for this?
Yes.
It is very much
there are treatments for a lot of these things. And sometimes it's a diet change for the baby, or, something that they're particularly missing that they can be given to extend their life.
Or something that something that you can look out for if your baby's not hitting their milestones, or then you'll know why, and you're not just going to be confused and trying to seek out all these specialists and all these physicians appointments, etc.
Yes. And I mean, yes, you are allowed to refuse it. We can't do anything to you or your baby that you refuse, but there could be no harm in knowing how to help your baby. And if you refuse, you do have to sign a refusal form on that, because it is state mandated, but it's truly for the safety and wellness of your baby.
Child. Yes. A lot of people think we're trying to collect baby's blood and we're going to send it to the state and we're going to sell genetics. Like, I have heard that so many times, but it's not necessarily true. So it is important for this test to be done.
Yes, very. Because, I mean, just think, if there's something that you could do to prolong your child's life or make it better, so that they didn't suffer the consequences of some hidden, disease
Sinister,
or disorder that was just lurking, and you can't see it with the naked eye. I mean, you have no idea until the symptoms are presenting themselves. And with some of these conditions, it's just too late. And with some of these conditions, it would be as simple as a dietary change. With some of them.
Very true.
Now, not with the SMA, but there are, I know that there's medications that they've developed over the last few years that prolong the lifespan for those children.
Or can help modify, like with the dietary ones.
Absolutely.
The galactosemia and
so, who doesn't want that for their child? Diagnosis is always scary, but it's better to face it and do what needs
Be
to be done
prepared.
to treat it.
Yes, be prepared.
And know how to handle it, than just going in blind and not having any idea what to do. So really think long and hard before you decline any of these tests, please. And you can always decline. We're not going to do anything to your baby that you don't want us to do.
Yes.
But I
even if you don't
encourage.
Yeah, just like that. Even if you don't immediately decline, even if you say, "Hey, can you give me a few minutes to look this up and like chat with, let me talk with my partner about it or support person. Let me talk with somebody about it. Can I look it up for a second first?" That's fine.
And we've even got forms we can give you with information.
I will give you whatever time you need. You talk about it. You let me know. I would rather you to be educated, and I can educate you as much as I know. But yes, educate yourself by whatever means. So yes, we're not here to hurt your baby. We're not here to steal your information. We want your baby to be okay. We want your baby to have a good life.
Yes. 100%.
Let's see.
So what do we want to talk about now?
So I was going to say one of the other things that we test for is the jaundice.
Yes.
In which we'll do the forehead scan first, which is just I'm always terrible at this word. The TCB meter. Thank you. So
TCB is transcutaneous bilirubin.
Thank you.
So basically we just have this little meter that we press to your baby's forehead and or chest 3 times, and it gives us an average reading of that baby's jaundice level. So there's a whole formulation.
Yes.
We have a nomogram that it plots on a graph according to the age and hours that your baby is, because, what's good at, if your baby's
30.
PCB number is 6.0 at 24 hours, that's great. If your baby's number is 6.0 at 6 hours,
We have problems.
not great. And we do see that.
So yes, like it is based on hours of age. So that's not specifically something that we can give you a number and say, yes, we want it below this, this number at this time.
Really depends on that exact moment in time. Now, if you want, sometimes I do pull up that graph to show my parents.
Yes, I do
and
too.
to show where it plots on it, because it makes so much more sense.
It does.
But if I'm just telling you, you're going to be like, wait a minute. That number was fine earlier.
So we'll do the meter check. If that yields a high result, we will draw a little bit more blood. We generally try to do that when we are doing the newborn screening, and that's when we do the blood spot card and drawing a little bit of blood from baby polyester's heel here. So I like to consolidate those so that I'm not poking baby unnecessarily. So we'll obtain what's called a serum bilirubin. Basically, it just measures the bilirubin level in the blood, and we'll ensure that that number that was on the meter is an accurate number. Because if it's not, then okay, well, sometimes it's going through the skin. It can read differently for different ethnicities, or if baby's bruised, things like that.
Mm-hmm. And so if you're wondering, what the heck is bilirubin?
Yes.
I get this question all the time. So our bodies are naturally breaking down red blood cells all the time, even in us grown adults. We are
Did y'all know
constantly,
that? Your blood has a lifespan.
Yes.
It is not
it's
forever.
Like 30 days.
Yes.
And your body's making new blood cells all the time. And they don't all die off at the same time. It's just some do and more come in. And that's one of the things, if you've ever heard of people getting this, I'm going to wander down the rabbit hole. If you ever hear, of a hemoglobin A1C, if you're diabetic or know a diabetic, they get that tested every now and then. And what that gives you is what the blood sugar's been over the last 30 days. And that's because those blood cells, you still have blood cells in your body alive from 30 days ago. So your body's going to tell all your secrets.
It's going to tell all your secrets.
You've been eating. So,
you can't eat good the day before, then expect that number to be normal. Nope.
Okay, so I'm going to put the train back on the tracks now. So, saying that your cells, live for 30 days and then your body generates new ones. So, the same thing is happening in baby's body from the time of birth. It is turning over those blood cells, making new ones, and your body is breaking those down, and then the liver processes those
the liver,
cells.
The liver grabs those and then decides, okay, we need to excrete these, and these are usually excreted in the stool, which is poop, and then the urine, which is the pee. So, but yeah, things affect the bilirubin, like if baby had a traumatic birth or just turning over blood cells that are from mom still in baby's system. It's not saying that your baby's having issues with the liver. What it's saying is
it's just immature.
It's immature. Yeah. So it can be immature, and we're just still that's why we check this. If the bilirubin gets too high, it can cause a lot of issues. And this is a preventative to making sure that the baby's jaundice level, bilirubin isn't too high, hurting baby.
Yes. And so the skin actually turns yellow from those red blood cells that are broken down, and the body has not excreted those yet. And so, and that can, like we said, if baby has a lot of bruising, just even from birth, facial bruising, or what we call a hematoma, which is where a lot of blood gets trapped, usually, on the scalp.
And those cells are going to get broken down.
And it starts to break down in the body. So if the baby has a lot of bruising, that's typically a big risk factor for a higher jaundice level.
We're clogging up our little liver here.
When the baby has a lot of jaundice in the system, high level of bilirubin, that can affect the brain, called kernicterus. Now,
that's a good baby name.
Oh, is it though?
No, we can call him Nick. Kearney. Okay, I'm so sorry.
Oh my gosh, Sarah. Kearney, baby.
So
Kearney.
yes, kernicterus is very detrimental.
Yes. And so, is it common? No. But can it happen? Yes. So we want to help baby get rid of all that jaundice out of its body. So what are we going to do? We're going to feed baby more than what we normally would.
Remember when I said it comes out in the poop and the pee?
Mm-hmm. The more you're pooping, the more you're peeing, quicker that number's going to come down. So I usually tell my moms, feed the baby as much as you can.
Yes.
But even if it's just at the breast, we can always, if it's pretty high, we need to supplement. If it's that high, typically we're going to start your baby on phototherapy, because those blue lights, what we do with that is we strip baby down to diaper only, and we put some little protective eye goggles on baby.
Which is not the hat. I really should bring some of those in.
We will. We'll bring those in.
But yes, they have little sunglasses.
Yes. They're really fun.
So baby gets to hang out under the phototherapy lamp, which usually we have multiple sources. We've got them on a little blanket with overhead lights, one if not two. Sometimes I like to do two. I like to cook them. And yes, we want as much skin exposure as possible, because it's permeating the skin, and those UVA and UVB lights are helping break down the bilirubin by permeating through the skin. And then that will help baby digest and process that a little faster. That's why you probably have heard the old wives' tale, or put the baby out in the sun. Like that will help baby's jaundice. Yep. level.
It will. And a lot of mamas like to, take their baby by the window. I mean, I'm not saying it's not going to help, but
this is a more intensive way of doing
you may be in the hospital for days.
Yes.
If you're just relying on that.
Yes.
Sometimes we can put babies under phototherapy and they can come out in 12 hours. Sometimes it takes a couple of days. But typically when we do get babies, jaundice level down where we want it to be, then we turn everything off. Then we can swaddle them back up, put them in their little clothes, and get all the snuggles all the time. And then typically we'll recheck a number, in 6 to 8 hours to see. Some babies will rebound and it'll start getting high again. I've had babies had to go under lights 3 times.
3 times. They just keep rebounding.
Yeah.
Yes.
So we have to make sure your baby's at a safe level before they can be discharged home.
The good thing is that this can be done in the room. The baby is not going anywhere. It's not going to be admitted to another unit away from you. It can be done in the room. And yes, the lights are annoying and they're blue and you feel like you're in a fish tank for a few days or hours, but it's done in the room. It can help baby that way that you can all go home at the same time. That is the end goal, that you all go home at the same time.
It is extremely rare that I've seen a baby have to go to NICU, unless they were readmitted. Anytime a baby's ever readmitted, they don't come back to mom baby. They go to the NICU or a pediatric unit. But as long as they're there with us, typically that's where we do it. I've only seen a baby have to go to NICU a couple of times for bilirubin treatment, but that was, like I said, an extremely dangerously high number, and they have to go get a blood transfusion.
Yes, they do a blood transfusion.
Correct that.
So if your baby has to be under phototherapy, we have the special equipment. We talked about the overhead lights, which is, we measure that as well. It's not just like an arbitrary, I think this is working. No, we measure the number as well. We want to make sure it's in a safe range. So we've got a meter for that. But we'll have baby on a blanket, we'll have lights over baby, and we'll have baby in a special swaddle. When that swaddle is very thin so that light can go through it and still give baby the proper treatment. What we don't want you to put clothes on. We don't want you to put 15 blankets on baby. I promise you, your baby's not cold. For whatever reason, those phototherapy lights will radiate a good amount of heat. Sometimes I've checked baby's temperature and they're high.
Yes.
Because of those phototherapy lights. So because baby's undressed and receiving phototherapy, they are not necessarily cold. And that's why we check that. So yeah, we have a specific meter that will measure that. We want it within a certain range. We don't want baby, it's not going to burn baby's skin necessarily, but we don't want it so close as that to it just over treatment.
Right.
Yeah. So the lights themselves are specifically calibrated. They only emit a certain number of UVA and UVB frequencies. But we do have the meter to make sure that nothing happens to them and to make sure it's within a safe range.
Yes. And all hospital equipment is actually checked
regularly.
Yes. We have special little stickers saying that they've been checked out by our biomed department, and everything is safe and good to go.
And if you go home and put your baby out in the sun, please be cognizant that that's only for a few minutes at a time, and please use sunscreen, and also consult your pediatrician before you do that. But yes, our equipment, it's not intended to harm baby, and it's not like holding them out in the sun. So
yeah, I've never seen, the only thing I've ever seen evidence after is babies will look like raccoons.
They do.
Sometimes.
They get their little face mask. I call it the superhero mask.
Yes, because they'll still be yellow right around their eyes where the mask was.
And where their diaper is sometimes.
And that's when you really realize how yellow they really, really were before you started, because the light will kind of wash out their skin.
Yes.
They almost look like they
got bleached.
They've been bleached.
There is an episode of SpongeBob where he goes out in This is so stupid, but this is what it reminds me of. Where he's out in the sun, he's sunbathing, and while everyone else is getting tan, he's getting bleached. And that's what the babies remind me of. I don't say that, but yes, instead of getting tan from those lights, it kind of does, like she said, it washes out their skin, reduces the yellowing, so they look a little bit more pale. And it just cracks me up. I'm like, it's SpongeBob.
Now, if you have a baby and they have to have phototherapy, that's what you'll think of.
Yes. What a mess. So that's it for jaundice and the phototherapy, I think. Let us know if you have any questions, if we didn't answer something. So, and one of the other things we do, and this can vary from entity to entity. Our facility offers the first hepatitis B vaccine when we do babies' newborn cares. With the hepatitis vaccine, it is not mandatory.
Correct.
It is. I can't think of words right now. I forgot words.
It's completely optional for you.
Thank you.
Some parents want to have us do it in the hospital. There's some parents who want to wait and do it in the doctor's office, which is totally acceptable as well. And then there's some parents who don't want it at all.
So let's talk about what hepatitis B is. So hepatitis B is a bloodborne infection. And as is hepatitis C, but hepatitis B, we have developed a vaccine that can give your body some basically immunity. So if you were to, or your baby were to be exposed to that, whether it be a needle or, God forbid, a blood transfusion, that can be the hepatitis B vaccine in its series can protect them from that. Now, you're saying, my baby's not crawling right now. Do I have to have it right now? Not necessarily, but talk to your pediatrician. If you particularly yourself have hepatitis B, then yes, we are going to recommend having your baby should have the hepatitis B vaccine, as well as another one that's called the HBIG, which is the immunoglobulin to help your baby to not develop that as well.
And those are typically given
right away.
Within the first, I believe, 12 hours,
yes.
They have to be given
Yeah,
together.
we usually get it as soon as they get to the floor.
Yes.
But if you're choosing to wait, that's fine. Talk to your pediatrician. Some facilities, like if you're planning on sending your baby to daycare or under another care provider with other children around, they may require it in their facility.
And here in Texas, it is required when they start kindergarten. Of course, there is, exemption forms that you can fill out with the state and everything to avoid that. But it is one of the ones that's required for kindergarten. Required.
So that is the only that's the only vaccine that we offer
that's all
in
we
the
do.
hospital if you want it. Some facilities offer it at 12 hours. Sometimes we do it at 24 hours. Some parents like to wait till they go home. In the NICU, they like to wait till they go home, until the baby's above a certain weight, so that has that muscle mass. Now, that is something that we give in their little thigh. Usually I do it the opposite thigh when we do the vitamin K after delivery, but I usually we give it on the outside of this little muscle mass right here, so it's got some place to go. We don't give it in the arm. We don't give it IV. We don't give it in their little bottom. It usually just goes right in the thigh there. But that would be, if you opted to have that for your child, it would be a series of 3 generally.
Yes.
So,
birth, 2 months, 2 months, and
6 months. And then so the following ones, the subsequent ones, would be at the pediatrician's office. Okay. I think that's the last aspect of our newborn cares.
Yes.
Other than we did the weight. We don't do eye exams in the hospital. I get asked that quite frequently. That's not a necessary thing. No. Now,
I have seen, really, how could you? But I have had, I don't know, it was probably a year or 2 ago, we had a baby born that, as the physician was doing the exam on baby, she noticed that the eyes were just like, it was all pupil,
Yes.
So, they do look at their eyes, but other than that, there's really no way to test them.
they're just checking for the reflexive.
Yes.
Like that's,
Yes.
you'll notice the pediatrician, when they do their initial assessment, they'll do the reflexiveness of the eyes. Sometimes in the NICU that's done, but that's like eye exams are done.
Yes.
But on our well baby, your general postpartum mom baby unit, that's not a required test before you go home.
Right.
We do the newborn testing and everything, but your nurse and your pediatrician will do overall exams on your baby. And we do, just like we do a head to toe on you, we like to do a head to toe on baby as well. And that it does include a few things that might be a little scary, little suspect. So of course we like to, I don't know why she has a hat under a hat, but she does. We like to check their fontanelles, and which are like their soft spots. We like to check their sutures, which are their scalp
Where the
lines,
bones
where the
come
bones come
together.
together. Babies are made to squeeze down the vaginal canal. So sometimes they're...
It looks like they have a ridge
Yes.
in their heads sometimes.
So we like to check those. We do kind of overall, making sure eyes are opening a little bit, or if eyes have drainage, things like that. Nose is congested, if there's anything significant there. Basically anything that may just be standing out. Mouth, sometimes babies will have, usually this is seen on an ultrasound, but like the cleft palate, cleft lip, that's something that will need to be addressed with feeding issues. We'll check their clavicles, so we'll kind of mash on them on their little collarbones here. We check their little reflexes. Sometimes you'll see us do this, and it looks like we're throwing them back down on the table. We're not. We're just checking their reflexes. We want to make sure they have the appropriate reflexes. We'll kind of press on their little bellies. Yes, we do undo their diaper. We do need to check a few things. We like to check their hip mobility. Sometimes if there's like a hip click, that's something that needs to be further investigated. We do check their genitalia. So if you see a nurse, doctor, whoever coming in and checking that on your baby, it's normal. That's what we do. We need to check their genitalia. We make sure
that the anus looks patent.
all their
the
holes are
really there.
Their holes are holes.
Yes.
Yes. Also, testicles. We check the testicles. We'll do a little squeeze. We're not trying to tug them off. We're trying to see if their testicles are distended or not, because sometimes babies will not have completely distended testicles, baby boys, and so sometimes they can be stuck in the groin area.
Or sometimes there's a lot of fluid on the
I was going to
scrotum
say that
as
sometimes
well.
there's a lot of fluid, especially if babies breach. Those
Yes.
can be swollen.
Yes.
So swollen, bruised. So that's something that we're checking for. We do, again, flip them over. Again, it looks like we're throwing them all around. Promise we're not. We do check them over on the back side. We make sure they have normal spine curvature from what we see from the outside. We check and make sure if there's a sacral dimple, if there's
that we can see the bottom of it.
Yes. If they have a dimple in the back and it looks like it's going down, like we can't see the bottom of that dimple, they'll probably do a spinal ultrasound. That can lead to other spinal disorders, so we double check that. We check their movement. Another reflex is step reflex. So we kind of hold them up and make sure they're kicking their little feet like they're supposed to. They have various amount of neural reflexes that we try to check for. So if you come in and see a nurse or doctor manipulating your baby, flopping them around, checking those things, it's a normal part of our process.
Yeah.
We do head to toes, making sure babies are okay.
And we're not being rough.
Yeah, I promise. I know it does look like we're throwing them around, but they're
really not.
They're tougher than they look.
Very much so.
So, and if you have questions during your baby's newborn assessment, ask.
We'll
what are you
walk
looking
you
for?
through
Yeah, we'll walk
everything
you
that
through
we're
everything. Sometimes we'll get the newborn rash. A lot of are super, super common. Our babies will develop a newborn rash, and it just looks like you laid your baby in an ant pile, and there's little bug bites everywhere. And that's not what they are. I will get a call and say, there's a bug somewhere in my baby's bed. And I'm like, no, it's a newborn rash, which is, as I learned from Delena, it's hormonal.
It's hormones. It's mom's hormones coming out in baby. And sometimes you'll see the little white spots all over the nose. That's called milia. That's also very common. And little girls will have vaginal discharge or even sometimes bleeding. Which scares a lot of mamas sometimes.
Yes.
And that's all very normal.
Dads too. I'll
Yes.
tell that a lot sometimes during discharge, and the dad's like, I am so glad you told me.
Yes. Yes. So it's all hormone related, and it will resolve on its own.
Something too, babies in different ethnicities can have what's called Mongolian spots, which are darkened areas, which are normal. Sometimes they go away, sometimes they don't. And usually they're on the backside or the extremities of baby. And we note those because if it looks like bruises, we want to be able to differentiate. We usually tell you, I like to tell my families, hey, these are called Mongolian spots if you've never seen them before. They're not bruises. They go away. It's just part of the skin.
And it's not always on, I would say most commonly it's lower back and bottom.
Yeah, but sometimes
it can be
anywhere.
Yes.
Yeah, it can be anywhere. A lot of I've seen them sometimes on arms and legs. Well, a lot of times on arms and legs, and the parents think it's a bruise from delivery. I'm like, oh, this is actually a Mongolian spot. Here's this is how I can tell. Also, it's noted too, because if something happens to baby, God forbid, in the future, and then, baby's suffering some sort of abuse, they can go back and say, is this a Mongolian spot or is this a bruise? So
Yes.
What am I missing on that? There's a lot of things we'll check for. It's really kind of cue based, because when we're going through it, we're like, oh yeah, see that, see that. I feel like it's just so ingrained.
Absolutely.
Yes.
I can't think of anything else with this assessment.
So it is normal, like I said, for us to manipulate poor little polyester all around here. Then we put her little pants back on, so she's not peeing everywhere. Circumcisions. That's something that we specifically no longer do in our hospital. If that is something that you are interested in, talk to your chosen pediatrician and the pediatrician who sees your baby. We used to do them in our hospital, but now we have to refer to an outpatient urology clinic for the baby. And usually it's done like within the day. It's when we used to do them on our floor, it was in and out within an hour.
Oh yeah.
And done. And then and the longest part was us monitoring
it's usually like 10 minutes, if that, to actually do the procedure. So we do what's called a timeout to verify that we have the right
baby
medications, the right baby, we have the consent. We're charting the times, and then the procedure's done, and then we monitor baby, and then again 30 minutes later, so we keep them with us for that full time, and then the baby will
come
get
back
out. Yeah.
So if that's something that and that's a family choice, obviously, if that's something that you're interested in doing, then talk to your pediatrician, and you can also call the hospital and talk to them and see what their current policy protocol is. Some pediatricians will do them in office. Some hospitals have private pediatricians that come up there,
or even
to do
OB
them.
doctors.
Some OBs still do them. So yes, talk to your hospital, your obstetrician, whoever it may be. There's different methods in which to do a circumcision, also requiring different healing recoveries. So yes, discuss that with your healthcare provider. It's something that, if that's something that you opt to do. Okay. I think that pretty much covers it.
I think so.
For the basics without getting too into detail, but please let us know. Drop us a comment. Drop us a concern. Ask us if you have any questions.
Tell us if we missed something.
Yes. I'm sure there's a lot of stuff. I'm like, oh, I'm going to do that on an assessment. I'll be assessing a baby. And I'll be like, I forgot to mention that.
But hopefully we've got a lot of episodes left to come.
Yes.
And we will go back and we will make corrections or additions anytime we need to. No shame here.
And like as Delena was saying earlier, if you've got questions about something as it's happening, you are recovering, your baby's in the hospital, the pediatricians are in there, ask. We'll let you know. We'll tell you anything. What are we doing that for? Why are we doing this test? We will educate you. I don't want you to be in the dark.
I feel like education is a huge part of our job.
It's a massive part of our job.
Yes.
This is why we're here.
Yay.
It's a lot of information to take in at once, especially when you're tired. You're like, what did they poke my baby for?
Yes. And there's always so many times we've said, oh, I wish parents knew this ahead of time. So that's what we're here to do.
That's what we're here to do.
We want to help you understand and anticipate what's to come in the future for you. So,
Okay. Well,
us
thanks
know.
for being here. Like, subscribe, come back and see us.
bye. Thank you for listening today. The Rattled Nurses podcast is not intended to provide medical advice. It is not endorsed by our employer, and we are not speaking on behalf of our employer. Our commentary and stories are our own.
Also, on a serious note, we want you to know that if you are feeling blue or depressed, it is okay. You're not alone, and there's always someone to reach out to. You can call the National Maternal Mental Health Hotline at 1-833-TLC-MAMA, or text the crisis line, text HOME, HOME, to 741-741. Remember, you're doing a great job. Now go warm up your coffee.